that have been trying for years. Some conceive quite easily, others have difficulties trying to conceive for a pregnancy. Other pregnancies are unplanned, so we never know exactly who we're meeting and where they are in the journey. Some people are well supported, whereas other people have a lack of support during pregnancy and after. They may have health issues, which is what we'll be moving on to shortly. Others are quite health literate. They know a lot about their medical conditions and pregnancy, whereas some people don't always know enough about it. So that's why we're here today, and we'd like to just go over some of the medical problems. Before we start, can I just ask you how long you've been a doctor for, and tell us a little bit about your journey into medicine?
That's a really interesting one. And I'm glad you brought that up, actually, because I do hope that there may be listeners that are thinking about careers in medicine or nursing or midwifery like yourself. So I must admit, obviously in our community, a lot of people think, oh gosh, parents must pressure and say your child must be a doctor. It was actually the other way round. I was that child that was always playing with a doctor's set. Age 3 or 4, I was obsessed. I just
knew from an early age.
Yeah, it was very strange. My parents they were supportive, but also, made it very clear that to do that you have to be dedicated and work hard and all those things. My father's actually a community pharmacist and has been for almost 50 years, actually still works in Birmingham. And so I always was at his pharmacy and seeing about medication and talking to doctors, and even as a kid just sitting in the GP practice just watching things. And so I did I did science subjects at school, got some work experience to sort of understand what being a doctor would be like, and then went to medical school. And actually my first job was in Wolverhampton.
Was it?
Yeah, so the first 2 years of my career, in fact, I spent a lot of time during medical school, which I went to Birmingham at Wolverhampton. And it's a community, an area and a hospital that's very dear to my heart. I was really well supported with some of my bosses at the time that really helped me in that early stage of my career, and I always thought it would be really nice to come back at some point. So I did my medical training and I decided that I wanted to become a medical specialist. And so I trained in what we call acute and general medicine. So you'll find that, if you go into hospital with chest pain or you have a heart attack or you have a chest infection or problems like that, you'll see a medical consultant. Yes. And that's usually me or my colleagues that do the same thing. I work with a wonderful group of colleagues at Wolverhampton. And then eventually I saw a lot of pregnant women that came in with medical problems, and it's not a specialty that's particularly well recognised. And I just realised there was a massive gap in my knowledge and ability, and a gap therefore of the care that these women need. So I actually found there was a professor in London that does this, Professor Kathy Nelson-Piercy, and I contacted her and said, look, I just need to train in this. Can you please train me? And so a charity funded my training because I was basically desperate to train in this.
Oh, wow.
So I was really privileged. There's a charity called the Lauren Page Trust. Lauren Page is sadly a girl a child who died because the mother had medical conditions, and now as a result the family raised lots of money to support the training and other research into medical problems in pregnancy. So really grateful to the Lauren Page Trust, who funded my training. And then I was really supported by the team at Wolverhampton to sort of come back and develop the service locally alongside some amazing obstetricians that are also trained in medical problems in pregnancy. So we work together as a team across Wolverhampton and Walsall as well.
Yes.
To look after such women, and it's very much a team sport, and I'm lucky to be part of that team.
Oh, well, we're very lucky to have you. We really are.
So it's great. Well, it's great working with you as well.
Oh, thank you. I think generally in pregnancy, if we can maybe start at the beginning.
Yeah.
So if somebody is considering a pregnancy or planning a family, they're kind of looking at what their medical issues might be or when to time a pregnancy. What do you think their pre-pregnancy counselling should be? Should they be accessing some counselling? Should they be seeing anybody before becoming pregnant, or do they just start trying?
So that's a really good question. What I would say is that, because there's going to be a broad listeners here, so if you are trying to get pregnant, the most important things are, as you say, to think about your medical conditions, but we'll park that for a second, I guess. It's to make sure that you are taking your pre-pregnancy supplements, make sure your weight is healthy and you're exercising, and then you try to conceive. And if you find that you aren't able to conceive within a year, it's important you then go to your GP and say, we've been trying for a year and we've not got anywhere, because that's the time to think about doing extra investigations to work out if there is perhaps a fertility problem going on. I hear and see a lot of women who and families or partners who try for a long period of time and don't seek that help. So I would say that to start with.
So you'd recommend about a year?
Yeah.
Okay. Does it depend on their age? Because sometimes I know women have said, oh, I've gone to the GP, they said you're too young, keep trying.
Well, really after a year,
Yeah.
then, there needs to be some thought as to why. Either, testing of the partner, or perhaps exploring your own medical history to see, actually, is there anything there is there a medical condition perhaps that we've not picked up that's leading to this? Is there an issue gynecologically that we've not thought about? So I would push for those referrals if nothing has happened within a year off contraception.
Okay.
But going back to your point about medical problems, it's really, really important to sort of, when you're thinking about having a baby, is to say, okay, what are my medical problems and how well controlled are they, and ask the advice. So the first place to go is your GP. And ask your GP, we're thinking of having a baby, are my medical problems stable, and is the medication that I'm on going to be compatible with pregnancy? It may surprise a lot of people to know that actually lots of medicines that you may be on for medical problems you can have in pregnancy. But it is very difficult to find a clear answer anywhere that will tell you that you can.
Yeah, I think a lot of women are quite frightened, aren't they? Especially, I've met women who are on antipsychotics or antidepressants, and they often come to me for that booking appointment and they'll say things like, I've just stopped all my medication.
Yeah.
So that's something we don't really advise, isn't it?
No, we wouldn't. And particularly to the point of antidepressants and antipsychotics, we know that mental health problems, you're not hopefully you're on medication for the right reasons, and it's really important to maintain good mental health throughout your pregnancy. So as a doctor, and all doctors will be the same on this, what we do is we look at the benefits of being on something versus the risks. Now, let's say, for example, that your mental health has been well controlled for so many years, and you're actually thinking, if I wasn't pregnant, obviously not just thinking, but having a discussion with your, whether it's your GP or psychiatrist, whoever you're under, to say, actually, I've been stable for many years, I'm thinking about withdrawing the medication, and you come to a plan together on how to do that, then that might be an appropriate thing to actually do. But if your mental health has only just become stable, or perhaps isn't the most stable, then you're right, we wouldn't want to stop anything abruptly. There's lots of antidepressants and antipsychotics that you can continue to take in pregnancy, and you will know this as well in your work. We sometimes even start women on that treatment in pregnancy because they have become so poorly.
I think breastfeeding's the concern, isn't it? Because I think, well, I'm having this medication, you've told me it's safe in pregnancy, but should I continue breastfeeding or start breastfeeding if I'm still on the same medication? So
there are some really good resources for health professionals, but also women, and there's a great app called LactMed.
Oh, never heard of that.
LactMed. It's more for medical professionals, but actually even on there, you'll be able to see if your medication is compatible with breastfeeding, and lots of medication actually are. So it's worth asking your GP. There are also there's multiple resources as well around. There's something called the Breastfeeding Network.
Yes.
There are resources through there that women can look up online, and their GPs can look up to actually find out whether medication is safe in breastfeeding. Even with some complex medication, I have to look it up.
Yeah, it's always best to check.
Yeah, it is always best to check. So don't be alarmed if your GP doesn't know, because they may not be familiar with it. It is sort of quite normal, actually. So as long as they look it up, and sometimes they still may not know, and I get lots of letters and correspondence from GPs to say, can you just give a bit of advice about something? It is always, as you say, better to ask and double check to provide that reassurance.
Okay, that's really useful. Thank you for that. In your experience as a doctor, what common conditions do women ask you about? What are common conditions that you come across?
Oh gosh, lots of things really. I suppose I wouldn't say common condition. In pre-pregnancy counselling, you mean?
Yes.
Oh gosh, all sorts. So everything from women who have had lots of complex surgery, perhaps due to bowel disease. There's a condition called inflammatory bowel disease that can cause inflammation of the bowels, and people can become quite unwell with abdominal pain, diarrhea. And that inflammation in itself, if it's very active in pregnancy, can increase the risk of blood clots. It can increase the risk of babies being born very small, or and babies coming very, very early. So it's really important that lots of inflammatory conditions like inflammatory bowel disease or inflammatory arthritis, that we know about these women, because we may even say, actually, if you're thinking about becoming pregnant and your disease at the moment, the control isn't great, now's the time to start even more stronger medication to get that disease under control, to ensure that you are healthy throughout pregnancy so your baby can be healthy too.
I think that's quite important, because a lot of people often do have different medical conditions, things that I've never even heard of. Sometimes they'll come and they'll mention something and I'm thinking, I have no idea what's going on there. But it's really important for women to know themselves about their own condition and what a pregnancy could mean for them with that condition.
Absolutely. So, I mean, it's very difficult really to give generic advice, but there are some really good patient support groups. So I've mentioned inflammatory bowel disease. Or colitis, and there's something called Crohn's and Colitis UK, which is a great patient support group, and they've got a pregnancy section on their website, and that can be really useful for women to look at if they're thinking of planning a pregnancy, because it will give them some advice, and then they can go to their doctor, either in the hospital or their GP, and if then they need further advice, they end up getting referred to myself and my obstetric colleague who do these pre-pregnancy counselling appointments. Similarly, if it's an arthritis problem, there's something called Versus Arthritis, again, a patient group. Yeah. So you'll find that lots of conditions will have patient groups that will have a pregnancy section. I look after a lot of women with multiple sclerosis as well, and the MS Society. They've got lots of, like I say, those things, but also free podcasts and webinars, and I myself do those on behalf of the certain societies that women can access as well. So there is a lot of resource out there. The trouble is, can be quite difficult to find.
Yeah, I think unless you're actively looking into your condition and wanting to find out more about it, a lot of these resources are probably not accessed as much as they possibly should be.
You're right, yeah, you're right. And I think we talked about this last time as well, about being your own advocate.
Yeah, definitely.
And how important that is. And sometimes, whilst I may be a doctor and a consultant, I've been doing this, 8-9 years now, there will be times when I see patients with such rare conditions that I've never seen before.
Yes.
I've only ever read of them in a textbook. And they are my teacher.
Yeah.
They will tell me, this is my condition, this is how I was diagnosed, this is how it affects me on a day-to-day. This is what treatment we tried and didn't work. This is what did work. And sometimes that's how things go. So my strongest advice to all women, and I've noticed this in women of our communities, that we sometimes are reluctant to take that ownership for lots of different reasons. But if my one message is to be your own advocate, or if you are supporting a relative who perhaps for whatever reason can't advocate for themselves, be their advocate for them.
Yeah, I think the more you know about yourself or your condition, the better, because sometimes actually you may be almost being treated for something that you either don't agree with or you may have more questions about, and it's a really good opportunity to raise that concern and talk to your doctors and say, look, explain that to me again. I don't understand it. Can you go over it again? It's really important that you do understand as a patient what's been offered to you, the treatment plan.
Yeah, 100%. And not only that, it's important for me as the doctor to know what those questions are, so I can understand you better and understand, okay, I didn't explain that quite right, or actually these are the biggest concerns here. This is what you're really worried about. And this is what we need to do to allay those worries, because those are the biggest concerns. So there is no harm in asking questions. Only good things come from it.
Yeah, definitely. While we're on that subject, a lot of people, when they've got especially rare conditions, I know from my own experience in my community, people look for things over the counter, or they'll, get medicine from back home. And, I meet so many pregnant ladies that have taken a treatment to help them get pregnant, and it's from another country. And when I ask them what it was, they don't actually know. So they're taking a lot of maybe herbal medications or things that they can get over the counter. What's your thoughts and views on that?
So that's really difficult, because I know that if you're seeking things like that, it's because it's for lots of reasons, really. You may feel like the NHS or the health system has failed you, or you're in a desperate situation. So my heart does go out to women who are seeking these sorts of things. What I would say is that we just simply do not know what's in them.
Yeah, I would agree.
You know, there's no regulation, really. And sadly, there have been cases where people have become more unwell with the treatment, the proposed treatment that's been given over the counter or herbal or whatever, than the problem that, you know, was already there. But I would want people to be honest. So just tell me, okay, this is what I've done. This is what I've been doing. Because sometimes when the condition deteriorates, you realise actually it's not the condition deteriorating, it's this whatever's been taken, and we just need to know. Yeah. So there's absolutely no judgment. I really wouldn't encourage it. And I would just encourage women and families to say that this is what we've been taking. The other thing I would say to your point is that we talked a little bit about fertility at the beginning.
Yes.
What I'm seeing now in my practice, particularly over the last 5 years, and again, I'm mentioning this because I know that women and families and partners only seek this because they are very, very desperate, is sometimes women go abroad for IVF.
Mm-hmm.
And sometimes they go abroad for IVF and, you know, the processes aren't always regulated as they are in the UK. And sometimes they have multiple embryos transferred over.
Yeah.
And sometimes they are having IVF despite having uncontrolled medical conditions. And as a result, that can put that can mean their pregnancy is even higher risk. And sometimes that's not explained to people when they have this IVF abroad, because this focus is solely on the IVF process,
it's
not
that desperation, isn't it? Just to become pregnant.
Exactly, which I completely understand. And I have a huge amount of, you know, my heart goes out to these women, but it's important to be fully informed about all of the risks, not just will the IVF work or not, but actually how is my body going to respond to this pregnancy, and how successful is this pregnancy likely to be with all of my other issues, rather than just thinking about the IVF alone. So again, this is about being your own advocate and asking these questions of people undertaking these things, about really talking about pregnancy planning. So going back to pre-pregnancy counselling, which I think was the original question, is the things we do in that appointment is get full information from the woman and the partner about what are the medical problems, and sometimes there's multiple, and where we are, how well controlled are we in some form of remission, are things more active, and if they're more active, we do everything we can in terms of changing things around to control the disease. We then talk about what medication someone's on, and and is that medication suitable for pregnancy and breastfeeding? And then we look at all the medical conditions and think, okay, how is this going to affect a growing baby? How is this going to affect all the factors in pregnancy? You know, will we need extra scans? Will we need extra tests in pregnancy? And how will the pregnancy growing itself affect the mum? And will we need extra tests for mum to keep mum well? And then we anticipate with anything, diseases can flare and we can have complications. Is there any risk of complications and flares? And how would we recognise that in pregnancy, and how would we treat it? So often women like this, they get very fed up of me because they see me so often in pregnancy because I'm keeping such a close eye on them with my obstetric colleagues and midwifery, looking out for these issues and problems, and then all the other things that can happen in pregnancy that we've already spoken about. So I always like a plan. I like to plan ahead and have a plan A, a plan B, and a plan C.
You have to.
Yeah.
You do.
But
really
also
do.
make sure that the woman and her partner are aware of that, so they know and are empowered to say, well, Dr. Pringer and my obstetric colleague said, if this happens, we need to do this, or we need to look out for this. And that information is power.
Yeah. I think on the subject of information, again, you know, I talk about it all the time, but language barriers. If you do have a language barrier, make sure that you're always spoken to with an interpreter. Ask for one if you need to, but all our professionals should be using interpreters with you, and you should fully understand. So all the information that Dr. Barrow-Pringer's mentioned, it should be explained with an interpreter should you need one. And they're easy to access, aren't they?
Yeah,
There's no excuse, really.
Yeah. So I find the majority of my clinics, about a half, if not three quarters, I'm doing in another language.
Yeah,
And that's okay.
yeah,
We have the services, and things are expressed more freely in one's own language.
yes, definitely. And some hospitals might use a telephone interpreter, others might use a virtual. You might have somebody on an iPad looking at you and talking to you, but don't be afraid to ask for an interpreter if you need one. So, moving on, can you just talk to me a little bit more about blood clots in pregnancy, please?
Right, blood clots in pregnancy. I think I might have mentioned
You've
last time.
yes.
Yeah, but it's very important. So I'm glad you're asking me again, because blood clots, or the fancy medical term, is called venous thromboembolism. And what that means is it means blood clots in the deep veins in the body. And we know that what happens in pregnancy is every organ in the body changes. The makeup of the blood changes to the point where blood becomes more sticky, and blood is more likely to clot. And that's a woman's body's wonderful way in changing to stop a woman bleeding at childbirth. So that balance can sometimes go a bit off, and the blood can become more sticky. As the baby grows, it can impede the blood flow from the legs back into the lungs. And the blood flow can become not as quick anymore. And all of those things can mean that clots are more likely.
Yes.
And when those clots occur in the legs, they're called DVTs, or deep vein thrombosis. You may have heard of people say wear socks on a flight because you'll get a DVT. DVTs can become more common in pregnancy due to pregnancy itself. And if you add to that, you're not walking as much.
Yes, mobility,
If you add to that, you're being sick, so you're dehydrated, that increases the risk of clots. Having had IVF in the first trimester can increase your risk of clots. Having had lots of babies, being slightly older, all of these things increase your risk. And if you've had a clot before, you're more likely to have a clot again.
and family history.
Family, yeah. So if you've got a strong family history of blood clots, you may have a disorder in the family that you don't even know about that increases your risk of clots. So what you will find is when you book your pregnancy, your booking midwife will ask you a whole series of questions, and to work out whether you're at high risk, low risk, or medium risk of having a blood clot. And if you are at high risk, you may be put on blood thinning injections throughout your pregnancy and until 6 weeks after baby is born, because that's quite a high risk period. If you've got some risk factors, you may be put on treatment from 28 weeks until 6 weeks after baby is born. If you are admitted into hospital for any reason, we know that being in hospital and being less mobile and
Increases your risk.
you're just not walking around as much, increases your risk of clot, and simply having an infection as well increases your risk of clots. Caesarean section does as well. So you may find that you sadly need to be on blood thinning injections, which we know is the only treatment for the clots, but also at a very low dose can be what we call a prophylactic, or reduce the risk of clots. It doesn't mean your risk is zero. So let's say, for example, you do the risk scoring and your midwife says you're high risk and puts you on low dose blood thinners. It doesn't mean your risk is zero. So you could still develop a clot.
I think that's what people always don't understand, because they just think, well, I'm having the injections, why am I still having these problems? So it's just making it really clear, isn't it? And for them to make sure they take the injections or medication every day.
I must admit.
We'll just head to a break and then we'll come back shortly. Welcome back to Maternity Matters with myself, Sunita Banga, and my guest today, Dr. Barrel Pringer. Barrel, let's go back to the blood clots that we were talking about.
Yeah, so we were talking about being on low dose injections, or what we call prophylaxis, for women that are high risk for blood clots. And we were just saying that just because you're on this prophylaxis doesn't mean your risk is zero. And the thing I can't emphasise enough, and I know having had injections like this myself,
Yes.
they're not fun.
No, I've had them too.
They're not fun, and
They
I get
sting.
it. They sting, and sometimes it can leave a little bit of a lump.
Yeah.
And I really wish I could develop a tablet or some easy option in pregnancy, but sadly we can't, because we know that the tablets aren't compatible with pregnancy. So I would really encourage women to take them. If you're asked to take them, really do consider taking them, and taking them religiously. So, like I say, it's not that your risk will be zero, but it will reduce your risk significantly. And even some women think, well, the pregnancy's over, baby's delivered, we're done.
I don't need them anymore.
Yeah. Actually, we know that your risk remains in the postpartum period, even beyond 6 weeks. But at the moment in the UK, we give the blood thinning injections until 6 weeks after, unless you're on treatment and we need to extend that treatment. So I really, my message to women is, if you are, it is suggested that you take it, please do take it, but also be honest.
Yes.
If you aren't taking them, or they're too painful, tell us, because, then we can identify you as being a higher risk. So if you do come in with symptoms like leg pain, which could indicate a deep vein thrombosis, or breathlessness or chest pain, which could indicate a clot in the lungs, which is called a pulmonary embolus, I will know actually your risk is higher.
Yes. What would you say to women? I met a woman, for example, a couple of months ago, and she said, oh, I've only been given 10 injections, I've missed 5, there's no point taking the rest. So what if there's like a gap and they haven't had them for a few days?
Please just carry on.
And should they finish the course, or just take the 5, which would have made it up to 10 days?
So if they've taken 5 and then stopped and then not taken it, finish taking the 5 at least, because the 10 days postpartum, just finish the course as best you can. It's really, really important. But then knowing that actually, like I say, I didn't take the full course, and if I still have issues like leg pain or breathlessness, I must get seen, because I could have a clot.
Yeah. It can reoccur, can't it?
It could,
happen after you've finished your course of
It could be
medication.
weeks. It could be weeks down the line afterwards. So if you've had something that increases your risk, like a cesarean section like that, you are still at risk weeks down the line. So it's just about being aware, not fearful of it, but aware of that. And I think the other advice I give women is that if you are prescribed these injections, take some, put a few extra in your handbag, or if you're going away for a few days, take a few extra just in case your plans get delayed or you change. Because the last thing you want to do is think, okay, I'm with family, I'd like to stay an extra few days. Oh, I don't have my medication, but you do.
Yeah.
And the other thing I say to women is that, we prescribe the initial doses and give you initial supply in hospital, and then ask your GP to continue things. But if for whatever reason you can't get hold of your prescription, please just come into hospital and get the injections. You're not bothering me by coming into hospital and saying, Dr. Pringer, I need a prescription.
Yeah.
I'll sort that out for you. I'd rather you do that than go without injections.
I think we do try and make sure, if they need them for 6 weeks, for example, I've seen a carry bag just full of injections. So we're pretty good at getting them for you. But occasionally, like you said, I mean, it may be that you've been sent home, you've been discharged, and you need to come back in and collect the rest. So just make sure that you do.
Yeah, or let's say you lose them, or, you're an antenatal woman, and we've said, okay, we'll give you a month, but the rest, I'll send you a letter and your GP will do it. If there's any gap or any issue, just contact whoever prescribed it in hospital, and we will arrange for you to have some. We just desperately don't want women to go without either treatment or prophylaxis, the prevention dose, as we've mentioned. So we talked about the deep vein thrombosis in the legs, and typically the symptoms of that are something that women should look out for. And the common symptoms of that is that it's usually in one leg. So you never really get them in two. And it's usually a sort of a throbbing pain in the leg, either in the calf and can be in the thigh if it's a clot that's high up. And the pain can be so bad that it can be difficult to stand. And in time, it can cause swelling of the leg and redness of the leg too, and it can feel quite warm. And if there's any of that, hospital straight away.
Yeah. heard people say if one leg seems bigger or more swollen than the other. I've never seen that. Have you seen that?
Oh yeah, lots of times.
Because I always imagine it to be a lump, and the ones that I've seen tend to be that hard, hot red lump.
Yeah, so it is usual. It is
Yeah.
common in pregnancy to get leg swelling.
Yeah.
But it's not common to get one
Just
leg
one,
more swollen than the other. And particularly swelling with pain. Swelling with pain is not normal. Normal leg swelling of pregnancy can feel a little bit tight and uncomfortable, but shouldn't stop you walking. And when, there is a clot in part of the leg, it can cause swelling further down. So that's the swelling that is caused by a clot in the leg. And, some women say that they try and sort of pinch their calf and they simply can't because it's so painful.
Too painful.
Or they really struggle to just put their foot down on the floor because the pain just shoots up the leg. Those can be common signs of a blood clot.
So what if this clot has now travelled up to the lungs? What symptoms would people most likely be displaying?
So in really severe cases, it can cause women to feel dizzy and collapse. Otherwise, it can cause chest pain that can be really sharp and tight, and they feel like they can't get their breath in. They're so short of breath. Now, breathlessness can be common in pregnancy.
Yes. We do hear it.
Yeah, we do hear it, we do experience it. But when when your breathlessness is so suddenly worse, or you can't do basic things like get up and walk or get up and put your clothes on because you're so breathless, these aren't normal symptoms. Yeah. And it could be signs of a blood clot, but it could be signs of other things as well. So again, very important to come straight back into hospital.
Yeah, and if you're over 16 weeks, it's always triage that you would need to contact. Prior to 16 weeks, always head into the emergency department. They will always see you there. But after 16 weeks, treat triage as if it's your emergency department. So if you've got any problems, always just give them a call. And your phone numbers will be on your app. So maybe save the number for triage. That's what I advise all my women to do, because you panic sometimes on the day that you need to ring them. You're trying to open this app and you can't find the number. So just save the phone number for triage. It's a really useful number to have in your phone, and you can literally speed dial it then if you ever need to.
And you may find you ring triage and they tell you symptoms and they still tell you to go to the emergency department, and sometimes that's the absolute right thing.
Yeah, it's just to get the right advice.
Exactly,
isn't it? And follow what you've been informed to do. So regarding stopping clots developing, what advice would you give? Do you think diet and exercise makes a big difference? Should they be drinking more? How can people avoid getting these clots? I know it's difficult. If you're going to get a clot, it's going to clot, isn't it?
No, I just feel
to
like
do with your blood.
Well, I just feel like I'm a bit of a broken record because I'm going to say it's about thinking about your own individual risk factors and planning ahead. So, it's worth knowing what, and we spoke about this last time. It's really worth knowing about your family history.
Yeah.
Asking your mom, your sisters, your aunties, parents, grandparents, have you had blood clots and when? And to your family, have you had blood clots in pregnancy? Really important to know, because that may affect you and your risk factors. Preventing things that cause the risk. So we know dehydration, and we know can be an issue, and dehydration can often be caused by hyperemesis or pregnancy sickness. So again, really, if you do have pregnancy sickness whereby you're barely eating, or everything you're eating is coming up, eating and drinking is coming up, really, really important to address that aggressively with medication to ensure that you can eat and drink and not be dehydrated. If you're in a long car journey over 3 hours, or you get a flight, to make sure that you are drinking enough water and walking around and doing all those exercises. And regular exercise.
Stockings.
Well, you can
get your flight socks, can't you? If you're planning, well, not that most people do travel too far in pregnancy, but do you think they should be wearing flight socks on an airplane?
Actually, with flight socks, the evidence isn't great for them. So by all means, you can wear them. That's fine. I think the bigger thing is to keep those ankles moving and keeping your knees moving, and walking regularly on a plane, and making sure that you are well hydrated with water, etc. If you're going to wear the right ankle socks, make sure you wear the right size.
Yeah, so they're not cutting in.
They're not cutting in. And a lot of women find that either the ankle socks or the TED stockings we give in hospital just make your legs so itchy, and they're so tight. So, yes, by all means, feel free to try them. But I think the more important thing is sort of what we call mobilisation, walking around and staying well hydrated.
You can keep it quite simple. So, and the stockings, sometimes they dig in as well. That can almost cause a tourniquet around your ankle.
Yeah, and they're not particularly sandal friendly,
Yeah,
are they now?
no.
And we know it's important to look the part
And
as
if
well.
you're going on holiday, you want to look good, don't
Yeah,
you?
yeah, absolutely.
Right. What about women that complain of headaches in pregnancy? When should they be worried? Is it a normal headache? Can they just be advised to have paracetamol and a rest? You know, have a warm bath. These normal things that we advise. Or when should they be worried about this headache?
It's a good question, because headaches, just generally, pregnancy
Common,
or outside,
yeah.
are common. But everything in pregnancy you just think twice about, don't
Yes.
you? So I think one of the things you've got to ask yourself is this headache normal for me? Am I a headachy person? You know, I know myself that if my eyesight isn't correct and my glasses prescription isn't correct, or if I've spent too much time looking at the screen and too much time watching telly, I will get a strain in my eyes and a bit of a headache, and it gets better after I take a couple of paracetamols. If that's you and you think, okay, this headache is normal for me, I know it's because my eyes are tired, I take a few paracetamol and that's fine.
Then
Which
we
you
don't
can
need to worry.
Exactly, we don't need to worry, and you can take paracetamol in pregnancy. You can even take ibuprofen up until the end of the second trimester. I wouldn't take lots of it because it's not particularly good for you if you take lots of it, but for the odd headache or bit of pain, it's fine.
Back
for a few
pain,
days.
yeah.
Yeah, for a few days it's fine, as long as you take it with meals. The headache symptoms to worry about. And then again, you know, a lot of women will say, actually, do you know what? I get migraines, not headache, because there's a big difference between a
Yes.
headache and a migraine.
And women know, don't they? They know if they're prone to migraines because they
Yeah.
probably have had them pre-pregnancy.
Yeah. And often, you know, migraines, often women will say, actually, I have a very distinct pattern of migraines. I know I do. I get them very infrequently. They're usually associated with my menstrual cycle.
Yes.
I will get, firstly, my vision will go. I then will get really bad pain on one side of my head, and then I'll start to feel sick, and I know I just need to go to sleep for a few hours, and it goes within a day. That's my usual pattern. So if you do get migraines, and I would say make sure you know it's definitely a migraine, not a headache, because some women say, oh, I get migraines, and you pick out the story and you realise it's never a migraine, it's just a
headaches,
headache.
yeah.
But they've been told, or they've been told someone...
Well, they just use the word interchangeably
which is
without...
completely understandable.
Yeah.
So the first question I often ask is, well, what's your normal migraine like? And if your headache is like your normal migraine, it's a migraine.
Yeah.
And some women in pregnancy find that their migraines get better. Some women find they get worse.
Yes.
And then it's a question of actually, what are you on for your migraines? And can you continue them in pregnancy? And you'll find that lots of treatment that we use to stop the migraine, like aspirin, like medications that we call triptans, or sumatriptan you may have heard of, ibuprofen, paracetamol, all of those things you can have in pregnancy, not ibuprofen later on. And actually there's lots of medicines that we use to prevent migraines that we can also give in pregnancy. So it's, if you know you get migraines, it's worth thinking about before you enter into a pregnancy, what am I going to do if I get a migraine in pregnancy? What's my plan? Yeah. And you can speak to your GP about that, or they can refer it certainly across Walsall, Wolverhampton, to myself, and we can talk about that. If you get a headache that is very different from your usual pattern of headaches, that is so severe that even with painkillers it's not better, that's a problem. If you get a headache where you get weakness down your arm or your legs, or your speech is different, or you notice a droopy face, or headache with severe neck pain, or a headache...
Would you put stiffness in that as well? Stiff neck?
Yeah.
Or would it just be the pain?
So if you get a stiff neck as well, and a temperature, those things are things to really, really worry about, and to seek help in hospital. We also know that the headaches can be associated with preeclampsia, which is a condition of pregnancy and a condition of the placenta. So if you know you've got high blood pressure, if you're getting a headache with visual symptoms, if you're getting a headache and you get some tummy pain as well, then it's, and you've got a lot of swelling in your tissue, your face feels swollen, your legs feel swollen. Again, that's one to ring triage urgently and get help. Those sorts of things are the things to really, really worry about. So a headache when you've got weakness in your arms and legs or your face, the worst headache of your life, a headache that doesn't get better with painkillers, one with neck pain, visual symptoms, And sometimes, in fact, some women get really severe headache and their family notice personality change.
Oh,
If your
never heard that
personality is
before,
really
yeah.
different, yeah.
Would that be the response to pain, or
It could be a response to pain, or it could be just something else going on that we need to do
Yeah.
investigations for. So if something doesn't sit quite right, it's not a basic headache that's you can take a few paracetamol and you're
just more
better.
than that,
Yeah,
isn't it?
yeah. If it's more than the usual, or it's the worst headache of your life, or you notice other symptoms, straight into hospital.
What would you say to women who maybe are on antihypertensive? So maybe they're already taking blood pressure medication, and then they experience these symptoms. Should they just continue to take the medication and go to sleep, or should they be going into the hospital?
So I think what's really important to know is that some blood pressure medication in pregnancy in blood pressure medication, starting it can cause a headache in itself. The important thing to know is that if you're on this blood pressure medication, what is your blood pressure doing? And if you've got the ability to check your blood pressure at home, that's a good thing to do. And if your blood pressure is normal and it's always been normal and you just have a headache that gets better with painkillers, not a problem. But if you find your blood pressure is high, or your headache's not getting any better, or you've got those symptoms of tummy pain, flashing lights or poor vision, your tissues are swollen, those sorts of things, seek help. It's better to ask.
Yes.
And, come in,
Get checked out.
and then, if it turns out actually it's just a simple headache, then it's just a simple headache, that's fine.
So you mentioned tissue swelling. Where would patients be looking for this swelling?
Hands, legs, if their face is more suddenly swollen.
So it's just puffy, is it?
Just puffiness can be a sign of preeclampsia.
Yeah. Feet, because that's a difficult one, because we do say in pregnancy you can get generalised.
You
can,
can,
feet swell.
but if it's suddenly got worse over a few days and it's never been that much of an issue before, and you also notice it elsewhere.
Yes. And it doesn't resolve, does it? Because normally with normal pregnancy swelling, we encourage you to elevate your feet, put your legs up, and that would decrease the swelling, really. But if that's not happening, and maybe you're not having any of the other symptoms. I certainly met a lady who felt okay. When she walked in, I thought, oh, she looks a bit different. And she said she felt the same, didn't particularly feel any different. Her blood pressure was high, but it was her feet. And when I looked at her feet, and you'd press, and my fingerprint was just left in her feet.
It's like that. So it's almost like dough.
Yes.
That you poke your feet, and it's still doughy.
It doesn't plump back up the skin.
Yeah.
So it's that's something to look out for.
Yeah.
You'd be probably quite unwell if your feet are getting to that stage.
Yeah,
so it's just being aware of the symptoms.
Yeah, absolutely. And that other thing that if it's not getting better with painkillers, that's a problem. But also in itself, if you take lots of painkillers, particularly cocodamol, and lots of codeine-based things, it can actually make headaches worse.
Yeah.
So you've just got to be careful, because headaches should get better. You shouldn't have headaches for days on end.
Yes,
so you shouldn't need to. Yeah, it's not normal. So you shouldn't need to take painkillers for days on end. And if you find you're doing that, there's a problem. Either there's something that we're yet to diagnose, or it could be due to the fact that lots of medication is being taken.
What about women who don't like taking paracetamol because they keep saying, oh, they're rubbish, they just don't work? What would you recommend for those ladies who are a bit reluctant to take paracetamol?
So I suppose for those women, it's women that perhaps have what we call tension headaches, that's very much sort of a tension-like pain. That can be very, very difficult to treat. Again, if I had a pound, if I could just make a cure for it, I think I could retire. But simple things really do help. So sometimes I say to women, relaxation techniques, massage can help. Again, that's after having a diagnosis of a tension headache by a professional. Massage can help. I always ask women to get their eyes retested, because they can find their eye prescription changes in pregnancy. And if their eyes have been strained for a long time, they may just have this headache that just doesn't go away. Sometimes if you've got the other thing that can happen in pregnancy is due to sort of increased blood flow, the sort of tissues within your nose can become more swollen. So a lot of women will find that they constantly feel like they've got a cold, or they feel nasally congested. That in itself can cause headaches.
Yes, it can.
So sometimes I say to women, steam inhalations to sort of just open up those sinuses can help a little bit as well. I'm wearing them now. I wear blue light blockers, so you can buy these over, any online, just glasses that get rid of the sort of glare in the light.
Yeah, and off your phone.
And off your phones, because we're always on our phones these days, aren't we? And that will help reduce your headaches. making sure you're well hydrated, so you're
Yeah.
drinking and eating
And
regularly.
maybe it sounds like a good excuse to have a nap to me. Just go and have a rest.
Yeah, but so funny you say this. I was having this conversation with the obstetrician in clinic. It's important to sleep,
Yes.
but not too much, because too much sleep can make a headache worse.
I must tell my sister.
Yeah, so I find that sometimes, naughty me, I catch up on sleep on the weekends.
Yeah.
And if I sleep in too much, I wake up with a headache. But
Yeah.
actually, there is a genuine
would-
neurological phenomenon of getting a headache if you sleep too much.
I would have to agree with you on that. I think I do anyway. I function better on just keep going.
Yeah,
So
yeah.
if I do have extra sleep, I don't really feel any better for it.
Yeah. So it's good. It's important to have a good
Yes,
amount of
you need
sleep,
enough sleep.
but not too much.
And that can be different for everybody,
Yeah,
can't it?
yeah,
So some people function quite well on
Yeah.
8 hours,
Yeah.
others 6, others need longer.
But yeah, you'll find a lot of women in pregnancy say, well, they're getting up so much to go to the toilet, their
Yes,
sleep is broken, and that in
yeah.
itself can cause a headache.
Yeah, yes, it can. And I think sometimes if you're not getting a good night's sleep, it's worth having that rest in the day.
Yeah, absolutely.
So what if the symptoms, if you've got any medical symptoms and they're not treated in pregnancy, what are women at high risk of developing?
So it really does depend on what the symptoms are. So, ultimately it can, and this is not to scare the listeners, ultimately it can lead to diagnoses that can really cause severe problems for mother and
Yeah.
baby. And in some rare cases, mothers dying. So this is why we're really here today,
Yeah,
not to scare our audience, but to say, actually, do you know what?
Just be aware. isn't
Be
it?
aware,
Mm.
ask for the help, and we'll get a diagnosis before things deteriorate. It's because, a lot of people just worry about their own baby.
Yes.
And they think, well, a headache or this, it's not a big deal, I can put up with it, but everything else is fine. So that's the severe end. But if you've got an existing medical problem, then it could just mean that problem does deteriorate to the point where it impacts upon you in pregnancy. And we want women to have
Yeah.
fun, healthy pregnancies. Just because you have
Absolutely.
medical problems doesn't mean you can't have a healthy, happy pregnancy experience. There just might be a few modifications. You have to see the likes of me and my obstetricians and midwives a little bit more. But we would still do everything we can to make sure that pregnancy experience is a joyous one.
Yeah, and we're just going to encourage you to do the things that are good for you, to keep
Yeah.
you healthy and well. What would you encourage women to do? So if they are struggling with problems, what kind of lifestyle would you encourage them to adopt? Let's just speak for a few minutes on that.
Yeah, so I think the important thing, one, we've talked about sort of being your own advocate and engaging with healthcare professionals and
Definitely.
just being honest about where you are and what you're able to do. Trying to maintain a healthy weight as much as
Yes.
possible. And, even if it's half an hour of walking 3 times a
Yeah.
week, that is really, really good.
I think diet and lifestyle are often really
Yeah.
underspoken about, really.
Yeah, and in terms of diet, a healthy, balanced diet, lots
Yeah.
of fresh fruit, vegetables, a good amount of protein. Try and, reduce our processed food as much as possible. I know those things are harder, but there's a lot more awareness now about how to do it in a realistic but also budget-friendly way.
Yeah.
Because, eating healthily doesn't have to be more expensive. So it is possible. There's lots of resources out there on how to do that.
Parol, you've been brilliant. Thank you for coming back a second time and talking about medical problems in pregnancy.
It's my pleasure.
It's been a pleasure to have you, and hopefully we can do this again soon. So thank you very much.
Thank you.